My name is Hiroshi. I'm assistant professor in epidemiology, and I'm coordinating this seminar for this academic year. So for those who have been in seminar last year, this is special. This year we are sharing a seminar with CORE, Center for Outcome Research and Evaluation, which is located in MUHC side. And today's speaker, Dr. Jonathon Campbell, is from CORE. So some of our epidemiology seminar will be shared with CORE this year. And I believe you all know the epidemiology seminar schedule that's posted in epidemiology seminar website. So if you need to know Zoom link as well as schedule, that's where you will see. And I think you will get email from the department as a reminder anyways. And for those people who are in CORE sites, yes, you are more than welcome to join. I believe the next joint seminar with CORE is this November 27th with Dr. Kevin Schwartzman's speaker, but we have many seminars before that. So if you'd like to join, I think you know where to join. And if you're not, please email me for talk. And I think for those who are joining the seminar first time, I mean, first year epidemiology and public health students, you know this, you need to attend seminars and need to fill in the sheet because it's mandatory attendance, I believe 60%. So please make sure to sign the sheet. So I think that's mostly administrative things. So before introducing Dr. Campbell, I'd like to make a land acknowledgement. McGill University is situated on traditional and unceded territory of indigenous people, including Anishinaabe and Haudenosaunee people. And I'd like to thank their presence, which shapes the land we meet today and exchange. So today's speaker, Dr. Jonathon Campbell, he's again from CORE, Center for Outcome Research and Evaluation, who is actually located in hospital, MUHC side of Montreal today. So we have 3 sites today here, and CORE site in person, as well as online. So it's hybrid. And Dr. Jonathon Campbell, the assistant professor in Department of Medicine and Public Health and Global Health. And his research focuses on improving prevention and care strategy for tuberculosis, with main aims to develop optimum strategies for the identification and treatment of tuberculosis, with particular emphasis among population who are born outside of Canada, who are subject to higher burden of tuberculosis. And Dr. Campbell published in many premier high-impact journals, including Lancet Infectious Disease and BMJ. And we are very excited to learn today's theme about economic cost assessment for public health interventions. So the venue is yours, Dr. Campbell, so please go ahead.
Okay, thanks, Hiroshi. You guys can all hear me? You just need to give a thumbs up to the camera if you can, Hiroshi.
It's good, yes.
Okay.
Just can everybody read? I think I don't know how to maximize. Oh, hold on, I know. Oh. Is this good? Yeah. Good? Okay, Jonathon, please go ahead.
Okay, great. Yeah, thanks for the introduction, Hiroshi. I thought, 70 people at the seminar was big, but I find out it's mandatory, so it's kind of expected.
Only for first year, but upper year people will join too, of course. We are
of course. Okay, so right, this is one talk in 5 seminar joint series, all focused on economic analysis and modeling. So I'll be the first speaker in this series. Then in late November, you have Kevin Schwartzman doing decision analysis. January 5th, we have Tim Evans doing health system financing. And on February 26th, we have Mathieu Mahoujerou doing dynamic transmission modeling. I'm trying to find one more person, hopefully for health technology assessment. So this is meant to be one of five talks. And today I'm going to go kind of the basics here, just trying to include costs in research. Research presented here, funded by CIHR and FRQS and WHO. I think this is a CME activity for some people, so I was told I have to put in learning objectives. So we want to be able to discuss the relevance of cost assessments to different areas of health research, understand different approaches to estimating costs, and describe differences, in my case, of caring for different forms of TB and how they can be used to support decision-making. So costs, what are they good for? Turns out actually something here, because healthcare systems operate in an environment of scarcity. Budget's not unlimited. We can't just keep going to the pot. We need to understand the impact of decisions on healthcare budgets because they are finite. Every decision we make has an opportunity cost. So if you decide to spend $100 million on one thing, you got to find $100 million somewhere else that you're going to take it away from. Okay, spend money on X, it's not going to be there for Y. Costs also help us identify high-value healthcare. However we define it, there's different ways to define what high-value healthcare is or how we should be distributing healthcare dollars, but costs and their consequences are essential to help us understand if we're spending our healthcare dollars efficiently and getting the most health for the least amount of money. So Wu-Tang Clan had it right that cash does rule everything around us. All right, done with those jokes. So clinical effectiveness or impact, insufficient for adoption. We can have a very, very good drug. Price is too high. If it's too difficult to implement, too costly, it's not going to be adopted. Economic evaluations and cost assessments can help reveal the potential impacts and costs of interventions in a defined population. They can support our understanding of the potential drivers of the impacts and costs of interventions. And because decision-making in healthcare is complex, economic evaluations can provide people who make decisions with more information so they can make a more evidence-based decision. So economic evaluation, considering cost, is definitely not the be-all, end-all, but they are essential to make decisions. It's just one of those things that we need to help us make healthcare decisions. So just some basic terms, by understanding the costs and clinical or public health impact or effectiveness of healthcare interventions, whether it be a new drug, new procedure, new diagnostic algorithm, these things are pretty wide-ranging. Reorganization of administration, method of follow-up, all these things are changes in healthcare that could have an impact on costs. You can support informed decision-making by understanding the costs and impact. So economic evaluation is the comparative analysis of alternative courses of action in terms of both their costs and consequences. As I said, it helps us understand, are we getting good value? Budget impact analysis is a process to predict and understand the potential financial impact of introducing a new technology into a system that operates in scarcity. We have defined resources. If we do this, are we going to be able to keep the lights on? We found some amazing new procedure we can do at the Glen, but turns out it's going to take all our overhead dollars and we can't actually pay for electricity if we did it. That kind of stuff. So you do your own economic evaluations, budget impact analysis every day. First-year grad students, we do this all the time. I know I did. All right, you're out at your favorite bar. If you don't drink or, kombucha shop, you're going to slam a few of those tonight. Tea store, sandwich shop, whatever it is. Okay, you have your menu in front of you. You got your list of beers, some fancy craft brewery, but they got the house lager there. It's nice and cheap. You don't really know what it is. You don't know if you're going to feel good tomorrow. You'll probably be hungover, but $4 a pint, and then you go escalating prices of different alcohol contents. Okay, so your choice of beer for the night is impacted by several factors, and they're not always going to be the same person to person. Okay, if you value flavor profile or alcohol content, depending on what your overall aim of the night is, you might value things differently. So your cost per drink, how much you're willing to spend might be different. That's like an economic evaluation there. You're understanding what the value is going to be. Okay, how many beers you want to be able to buy that evening? You bring 30 bucks with you. You want to be able to stay a few hours. That's your budget impact analysis. You know how much you can buy with the money in your hand. And then there's this other term I'll throw in there, which is elasticity, which all these things are variable, of course, based on how much you've had to drink that night, right? Everything can change. Things are fluid depending on the market. So we always do these things. This is an example for drinking, but it's also, you want to go buy a nicer car. You might not have money to do X. You want to go on vacation. You don't have money to do Y. We do these things all the time. We all operate within our own budgets. It's just trying to make it very clear that health systems aren't all that different. Okay, so what are the risks of ignoring cost effectiveness or an economic evaluation? So I'll give you a classic example. Probably have heard this before, colonic cancer or colonic cancer. American Cancer Society in 1975 endorsed 6 sequential tests on stool samples for occult blood to triage for confirmatory test to diagnose asymptomatic colon cancer. It's a very classic example. They endorsed it because you pretty much capture every single case. You did 6 sequential tests. Okay, sounds good, right? We found something we can definitely diagnose early. This is going to help interventions. You know, we can intervene early. Maybe we can prevent mortality. We'll forget about all the maybe biases associated with early screening in this case. You do this, you have 93% false positive rate as well. So you're also testing a ton of people who are never going to have, who don't have cancer with a confirmatory test. But what you don't think of is what's the actual additional cost of doing test 2, 3, 4, 5, 6 on a particularly small population to detect all cases, right? Because you got to be, basically, if you're negative at test 5, which is going to be the vast majority of people, you got to do another test. Okay, if I told you that the cost to detect one case with the first test in a population of the US was about $1,100, the cost to detect an additional case after that, so you've wiped out everybody who's going to be positive on the first test. Now you have everybody who's negative. The cost to detect an additional case on the second test was about $5,500. What do you think the additional cost would be by the 6th test to detect that one additional case? Keeping in mind these tests are not expensive. $47 million. Okay, by the end, you do that 6th test, you've had people 5 times, you have to do probably around 4.7 million tests to capture one more person that would test positive. So if you ignore cost effectiveness, you endorse this, you're really going to be spending a ton of money. I'm sure if you ran this through budget impact analysis too, you'd be kicking yourself. Yeah. Well, there you go. How long do you have to wait for them? You just forget it. Okay, so what are the risks of ignoring budget impact? Here's another classic example, direct-acting antiviral hepatitis C. Very effective, 12 weeks of treatment, 99% efficacy, wonder drug. Cost per day of treatment, though, is about $1,000 US. They're not cheap drugs. Yes, they're curative, but they are very expensive. Okay, typically found to be cost-effective, of course, when you compare it to the alternative, right? Of course. However, if you rolled it out, even at a very discounted price at the time, I know costs have changed, the cost of treating everyone who you'd want to treat with those drugs would exceed your entire budget for all medical treatment in many European countries. So there was countries like Poland that was twice as much as their overall healthcare budget to pay for every other medication through their reimbursement program. So clearly, if you didn't look, yes, cost effective, it's curative, this is amazing, but if you don't plan, try and roll this out, you're quickly going to run out of helpers. Cost effective, unaffordable. Okay, so considering costs, I think hopefully that gives us a lot less extreme, but they are important. You go through one of these comparative cost assessments, economic evaluations, it makes the alternative options very clear. Sometimes we're often very blind to what standard of care is. We just do it without thinking. We don't know all the other moving parts that are involved in current practice and how complex they might be. So doing this process really helps open your eyes to where costs are incurred. I'm not going to get too much into perspective and viewpoint. Those will be for some other talks later on in the series, but they may impact how attractive or cost-effective different options are. Do you care about costs to the health system, to society, to patients only? Where in the country are you implementing this? Are you implementing it rurally, urban? Are you doing it in the Atlantic provinces? Are you doing it in the territories? Cost effectiveness could be very different depending on location, scale, and where you consider these costs. And without explicitly quantifying these costs and consequences, our intuition and or informal assessment might be highly misleading. Direct acting antivirals, hepatitis C, very cost effective, but if you look at it closer, you would make a big mistake. Same thing with sequential screening for colon cancer. Systematically evaluating the costs and consequences of different decisions, therefore helps improve accountability and decision-making. The options you have in front of you can be scrutinized. They're not always ABC. Sometimes it's A, B, C, D, E, F, G. You have many options in front of you. This can help make them your decisions and the cost, the opportunity cost of making them very explicit, and helps us determine the social value of our options in the broader healthcare agenda. Okay, because basically the health system here, we're always trying to trim the fat. Okay, so costs are very important. They're really trying to get every dollar, the most value for every healthcare dollar we spend. Okay, so I'm going to shift now a bit more to my field, which is tuberculosis, targeted research. So this is a seminal clinical trial published in the New England Journal of Medicine I'm not going to tell you just yet. So published in the New England Journal of Medicine, it's looking at TB preventive treatment regimen. So typically we used to treat tuberculosis infection, which can progress to disease. Infection completely asymptomatic. You only would know you have it if you did a skin test or a blood test. Really has no symptoms. You would have no clue you had it. We treated it with 9 months daily medication. That's what the standard was for 50 some odd years. Then there was some research into, can we make this shorter and just as effective? And it's tough to do these trials because, you know, somewhere between 1% and 5% of people with evidence of infection will ever go on to disease. And it's a very long-term outcome. So these trials require long follow-up. A lot of people, they're very expensive. So typically they weren't done, at least in a large population group. So this is a big trial, several thousand individuals of a 3-month regimen looking at treatment of TB infection to prevent tuberculosis disease. Significantly shorter, 3 months now versus 9 months of the standard regimen. They found amazing results. Non-inferior efficacy, actually can take a look at it depending on if they were properly powered or not. Could have been superior efficacy to the standard of care. Superior completion for sure, shorter regimen, more people complete it. 82% versus 69%. Found to be much more cost effective for TB prevention than standard of care in the USA. Had higher rates of permanent drug discontinuation. So this is a red flag in the trial. 1% more people in the 3-month arm stopped treatment due to a serious adverse event. But actually, when you looked at it a bit more and in routine practice, you found that all of these adverse events were probably being overcalled in the trial because it was a new drug. And clinicians were being probably a little bit cautious in permanently discontinuing the regimen. This regimen called 3HP, 3 months of once weekly rifapentine and isoniazid, was actually found quite well tolerated, and the types of adverse events that were found were not as serious as a standard of care, which is kind of hepatotoxicity. When you detect it symptomatically, it's pretty serious at that time. And in fact, I'll tell you, this is now the first-line regimen in Canada. Okay, so I'll show you what the global uptake is in 2021. The most recent data WHO has is 5.3% of all people treated for TB infection globally received this regimen that we found is well tolerated, superior completion, just as good. So what year do you think this trial was done in? We're sitting at 5.3% in 2021. Someone who doesn't study TB. Okay, it's 2011, this trial, 10 years. Okay, so what gives with the implementation here? Like, really? Wins on everything. Could it be the cost of the regimen being a new drug? Costs were high. Sanofi developed it. Sanofi wants its money back. Never mind that actually took a lot of public healthcare dollars to do the research and now is milking the public system to get its money back. We'll talk about that another day. So it's in the USA, full course of medication, $150. Okay. Standard of care medication was magnitude cheaper, $13.50. Okay, this is a nice little timeline of, when it was finally, published in 2011, July 2012, they put out their price tag, $75 a box, 2 boxes for treatment. Okay, over the next 2 years or so, year and a half, they get it down to $32 a box. So it's no longer $150, it's now $64. Okay, this is in the US, but it's also, that price tag goes everywhere. Okay, so I'll give you an example from some work we're doing looking at scale up of these regimens in a few high TB burden countries. Okay, so here's the cost of the standard of care in a few countries. So Georgia, the country, Kenya, South Africa, Brazil, very low costs of 9 months of treatment, primarily because drug costs, it's about a penny a pill. Isoniazid, the primary regimen, off patent, 1 penny per day to treat someone. 9 months, they do very little in-person follow-up. Take the pills, come back if you need it. So low cost overall. United States, they do monthly follow-ups Everybody comes back in 1 month. How are you doing? We're going to do some additional blood tests. Typically not done in countries like Georgia, Kenya, South Africa, and Brazil. You want to bring in a new regimen, and you're going to tell them that you want to treat, literally the millions of people with TB infection in this country with a regimen that's now going to be 20 times as much, 3 times as much, 15 times as much, 8 times as much. It's not going to happen, right? So costs have finally come down, and today, instead of costing $150 for one regimen, it's now $15. So the costs actually drop, and in a place like Kenya, it's cheaper because they do actually monthly follow-ups there. So you have 3 follow-ups now, well, 12 follow-ups, but 8 of them are very quick. So actually the cost is quite cheaper. United States has now dropped. It's less than actually the standard of care. It's now a no-brainer. So cost, big barrier. Actually, this is the primary reason why countries didn't implement it. They simply couldn't afford rifapentine. You have this great drug, but countries are priced out. And the fact is, it's the countries who actually need the drug that get priced out. Big barrier to implementation. Okay. All right, so after that, I'll go in a bit, the range of these talks is a bit of methods and a bit of application. So cost assessment, just to kind of try and demystify this. Okay, this is from some work I did with WHO TDR, looking at trying to demystify cost assessment for some operational research. Most important thing is to understand your intervention, right? You want to put in new drug or new technique. I want to know exactly what goes into it. Who needs to be trained? What happens? Does the whole flow or the patient handling flow chart go differently? Do they see someone else different? What happens if X happens? Where do they go? You need to really understand what's going on in your intervention. It's not simply changing the drug sometimes. Sometimes changing the follow-up course, changing the tests you need to do. The way you make this really explicit is to construct flow diagrams. Like, what happens to the patient? They come in, this is what we're going to give them right now. This is what we're going to give them now. Does the pathway to getting to you change with your intervention? That might change too, right? So you need to understand what's going on before sitting in front of you and getting your intervention. Sometimes we don't know. I'm not a medical doctor. I work in the Department of Medicine, but I don't have an MD. I don't know what goes on a lot of the times before someone shows up to the clinic with TB. I need to talk to a lot of people who are involved in many different aspects of care. So it's not a straightforward thing. You need to really discuss, draw out these things, make it explicit. And I'm going to show you on the next slide why that's super helpful. And then once you understand what's going on in your intervention, you can then see where costs might be incurred and how they differ from what you're doing now to what you want to do. So take this example here. This is a very simple flow chart. It's trying to implement tuberculosis symptom screening in a high HIV country, a country with a high incidence of HIV, also with a high incidence of TB. So take a country like Ghana, which actually implemented this, and this is how things went in Ghana. This was the care cascade now. Previously, you don't test anybody for symptoms. They come in monthly or every 3 months now for their ART refills. There was no symptom screening. So we had to figure out what happens now. If someone is test positive on symptoms, what do? You go down, you see if they can produce sputum, right? It's not just a simple assumption that everybody's going to come in, they have symptoms. Not all TB symptoms are a 2-week cough or more. Some of them can be fever, night sweats, things where you can't really produce a good quality sputum specimen. What if they're a child? Not everyone goes there. So if we didn't talk to anyone, we assume, okay, symptoms, get sputum, do a test, and take it easy. Find out that people who can't produce sputum get a chest X-ray instead. So now we need to understand how many people can produce sputum and not. What happens if they are negative on any of these tests? Nothing happens, routine care, they come back in a few months. Maybe there's some differential diagnosis that goes on. But people who get diagnosed then are treated for TB. Would you consider the costs of treating them? That's not your intervention, right? It's just really symptom screening and what happens after. The fact is, some people would just stop here and not think about the costs of treating someone. But if you go from treating 100 people a year without this, and now you implement it and you're treating 200, you've got a big blind spot, because actually the cost of treating people are going to be extremely high, right? The cost per person treated in some settings. So also understanding all the downstream and when the costs stop is important. And this really is helpful to draw out and make clear. And when you look at what's going on the personnel involved on the right side, Yeah, they do. They perform the symptom screening. They do the further workup, sputum collection. Sample gets sent off to a lab where gene expert is done. What happens there? How do you get that lab set up so you can actually do a nucleic acid amplification test on that sample, get the report back, contact the patient, tell them the result, have them come back and, counsel them on what their diagnosis means, what's going to happen. Like all of those things you need to understand. It's not just simply they get told they're test positive. And upstream, there's training, right? You can't just say, ask people about symptoms. That's what we're going to do here, right? There's usually a few hours or some sensitization that happens. You got to implement something in the EMR where you're saying symptoms, yes, no, cascade down, right? These are all training costs that come upstream that you might ignore if you hadn't really worked it out. What's going to go into this? Okay, now there's some typical cost categories that things fall into. I think we would all also understand them intuitively. Sometimes it's helpful to write out. You have materials and consumables. These are like your recurrent costs, okay? If you collect sputum sample from someone, a sputum cup, that's your recurrent cost. Doing a test on nucleic acid amplification test, that's in a cartridge. That cartridge, recurrent cost, material and consumable. You have your staff and personnel time, your lab technician, your nurse, the physician, social worker, interpreter, people that are involved in care. You have hospitalization costs, very complicated. You kind of put these things a little bit differently, but they have every cost category in them, but they're quite unique as they're not standard. A hospitalization is very different patient to patient. Capital costs, so you're thinking equipment. You want to go ahead and put in this amazing new diagnostic. Well, it needs a $20,000 machine in every clinic in a country that can barely afford to buy the test, right? You need to understand what the capital costs are. You say it's $10 a cartridge. They're like, great, we can afford that. They're like, but you got to pay $20,000, 30,000 times so you can get in every primary healthcare facility. Well, now that's a bit of a problem. So you need to consider the capital costs of implementing. Then you have overhead subcategories in there, construction, furniture, electricity, utilities, custodial costs, things like that. And then infrastructure costs. So in the context of tuberculosis, if you're looking at costs of performing a tuberculosis diagnostic test, in this case, a nucleic acid amplification test, which is expert MTB-RIF, it's offered at the Glen now. Your consumables and materials might include the cost of your sputum cup and the cost of the expert cartridge. Your personnel would include the cost of the healthcare worker time to collect the sputum sample, the cost of the lab technician time to run the sample, the cost of clerical staff to contact the student to input patient information in the chart, et cetera, et cetera, et cetera. And you have your other costs that might include the cost associated with keeping the clinic open, the laboratory overhead charges, cost of that expert system. Do you have to replace it every 5 years? Well, now you got to consider that that's going to be a recurring cost every 5 years, and you got to figure out how to include that in your cost assessment. There's maintenance on machines. Things don't run all the time. Ever since I joined this department, I get 25 emails a day from my MUHC. Oh, this is down, pneumatic tube system. Sorry, guys, it's down. We got to do maintenance. Things happen, right? These things aren't going to have 100% running time. Okay, so how do you think about cost? What do you do? So you might have seen in the literature, if you've read about costs in the past, there's two primary approaches. One's bottom-up ingredients, micro costing approach. Did this nice little diagram here. You pick your part of an intervention. It's going to be your diagnostic test. You break it down. We're going to work from the bottom up into its various component costs. I went through, consumables, materials, personnel, and then you try and estimate what those costs are. Generally, you use this when estimating costs associated with treatment or simple screening and diagnostic algorithms. Things that you think are going to be pretty consistent person to person. These are nice and easy. Test here, test there, go on. So costs associated with TB treatment, you have your medications, pretty simple. How much does that reimbursement cost? Monitoring tests, which ones are being done, liver transaminases, CBCs, outpatient visit costs, directly observed treatment, okay? Some of these things you then see and you got to go break down, okay, what's involved in directly observed treatment? Go in, see a nurse who watches you take the drugs, ask you about how you're feeling that day. There's not just a little bit of time going into that. Sometimes it's much longer. Sometimes it's not just the drug cost. Tuberculosis diagnosis, you have symptom screening, tuberculin skin test, chest x-ray or CT, sputum culture, or a NAT. Varied. Tuberculin skin test, you can break that down even further. That there has personnel time, got to place and read that test. You need the tuberculin, you need the syringe, you need alcohol swab, right? Cotton ball if you're going to put a Band-Aid on them after, perhaps, or to blot the small amount of blood that comes out. No Band-Aid. But yeah, you break these things down and you say, okay, what goes into each test? And this is like literally all the ingredients that go into your intervention. Very resource intensive, a lot of back and forth. Top down is another approach. So now we'll work from the top down. You have an overall cost estimate that you want to split among different parts of your intervention, and you allocate it based on the number of occurrences per year. And that's how you arrive at your cost. So something called, you have a budget of, we're going to put $100,000 in the TB program. We treat 100 patients a year, costs us $1,000 a patient. There you go. That's what it is. It can get much more complex than that, but in a very simple example, thinking of the top-down approach, that's how it works. Well, maybe you have a budget. You say, last year we budgeted our TB program $100,000. That's what they spent, and they treated 100 people with that $100,000 budget. So however it was spent, right? So costs are going, you don't really know where all the costs are. Micro costing, you really have carefully accounted for all the costs, but you kind of miss some overhead things, right? You're not, you're assuming a perfectly efficient system, right? People take 5 minutes to do this, and they always take 5 minutes to do this, and they're never sitting around. There's never any dead time. Maybe that's true at a very busy hospital, but it's not always true. Top down kind of picks up those extra costs that go in, right? But it also brings in some other ones that, you're not really sure about, and it's a bit of a can be a bit of a black box. So you can use this generally for very complex unit costs or difficult to precisely estimate component costs, or things that might be highly variable patient to patient. So contact investigations, COVID, tuberculosis, any infectious disease, very variable depending on patient situation. How long have they been infectious? Where have they gone? Did they get on a Greyhound bus and go across the country? And they're like, okay, now we got to really get into it. It's not just the cost of a contact investigation. They're very different patient to patient. Sometimes it's better to say, what did it cost overall? All the money we put into doing our contact investigations. How many contacts did we identify? Here's the cost per identifying a contact, for example. It's useful for inpatient stays because they're generally quite variable person to person, especially, you have estimates that are for specific indications provided by CIHI. Not here, I don't think, in Quebec, unfortunately. Or very likely underestimated by your per diem costs. But here we actually have something different. So if you're in a Quebec hospital, something a bit more useful. So I just found this out. Been working here since 2018, and I just found this out actually a few weeks ago. We have at the MUHC, and all hospitals in Quebec are mandated by the ministry to collect cost information on every single hospital admission, every single one. So you can estimate the cost of inpatient admissions for your clinical studies here, right? And have them broken down in great detail. They know exactly what happened. Okay, need for specialist care, imaging done, indirect costs that get attributed to them, how long they stayed. They have everything except for blood tests. So you have to go into patient charts, extract the blood test information, how many were done, but they do have how much you get reimbursed. So they can tell you how much all the blood tests will cost. You just need to know what blood tests are done. So MUHC finance department, you talk to them, they offer the service. You give them the MRNs and what stay you're interested in during your study. They can tell you what that cost of that stay at the hospital is with great precision and information, and also provide you a reimbursement list for your blood test when you go into your patient charts to then fill out the extra ones. So person's name is Andre. I'm hoping he's not on the call. He's probably going to hate me for now. The service is free for now. Also anyway, I know we're in first, so just to say. Okay. Now it's my first foray in this. I don't know how quality, but I know it's offered. And I know they do this for audit reasons, so they've audited all the way up to, I think, mid-2022. And by the end of fall this year, they'll have all of 2022 done. So very comprehensive. Okay, I'll shift gears a bit now to doing costing for tuberculosis. So when I started my postdoc, it was in 2018. Cost of TB in Canada hadn't been estimated for about 15 years. Okay, so in 2004, study by Dick and Olivia and master student Megan here, looked at overall cost of TB and primarily focusing on programmatic expenditures. So programmatic expenditure, they say, how much did the TB program spend here and roughly how did you allocate it? This percentage to TB infection. Sometimes very detailed, you can get down to cost of contact investigations, which sometimes really useful for budgeting. You're saying, okay, we're going to expect, an increase year over year in the number of people diagnosed with TB, number of people that we're going to diagnose with TB infection, what we need to think about moving forward in terms of a budget, right, to make sure that we're funding these programs appropriately. It's going to cost you $300 to identify one contact, which is what they say. Then you better make sure that if you're going to have more people developing TB in the future, you're going to have to do more contact investigations. You can help understand some of those things. But it's not as useful for comparing the relative benefits of different courses of action because it's very top down, right? They said this is what got allocated. They didn't really look at the actual cost ingredients in a lot of cases. Very useful study, but if you want to use it for some other things, you can get better estimates. You can use these, but they might not be ideal. So you want to really understand the costs associated with discrete activities. So I started this in 2018. You can see it got published when I joined faculty in September 2022. So it's a long study. These things aren't simple, as much as I tried to make it simple. Sometimes they do take a long time. So we looked at the cost of TB at 3 treatment centers here, one Chest Institute being one. Another one was the British Columbia Center for Disease Control. Centralized province treats pretty much everybody in the province who develops TB. And West Park Healthcare Center, which is in Toronto, just off Jane Street. Very complex patients in Ontario get sent to West Park Healthcare Center for care, primarily multi-drug resistant TB, where primary regimen has failed. So our aims here were to estimate the health system costs associated with caring for TB infection, drug-susceptible tuberculosis disease, and 2 forms of drug-resistant tuberculosis disease, which are more resource-intensive to treat because they're either resistant to isoniazid, the first-line drug, or resistant to isoniazid and rifampin, 2 of the best drugs against TB, and we call that multi-drug resistant tuberculosis. And we also wanted to determine predictors of these costs. Okay, so most TB care is provided on an outpatient basis. So you can't exactly go to our finance department and say, tell me what the cost of TB is. So we conducted individual chart review on up to 30 individuals per site each, with each form of TB. So equal to about 120 patient charts per site. Extract detailed information on patients from diagnosis, well beyond treatment completion, lots of time and energy, who's ever done a chart review, plenty of re-review. Got a shout out to the students who did this because it wasn't me, who went through all the charts. I think Placide was here. Placide has now since left, probably because he was getting a little bit of traumatic response to seeing this. But him and Ashna really sat through a lot of the charts here. We defined different periods to cost. So diagnosis, want to know what the cost associated with diagnosis was, of treatment, the treatment phase, any hospitalizations, post-treatment follow-up phase, and then the public health costs. So this is a different angle that you might not think of in sometimes clinical care, right? There's costs associated, contact investigation is one of those. It doesn't show up in a chart, right? Maybe the number of contacts identified does, but all the costs that might go up into identifying and then doing whatever follow-up tests you need to do on contacts is not calculated. Okay, so we need a uniform data extraction forms for each participating site for patient information, everything you want to know, demographics, clinical characteristics, and patient care and costs. So this actually took like a year just to get down at 3 sites to get something that's fully inclusive. Like really a lot of back and forth. We turned out to 201 different costs. So you make a sheet, you think unified between all of them, you think it's really good, passes ethics. You go in and to your first chart, you're like, forgot this, this, and this, because why on earth would we think, this person would get this adjunct treatment here? Oh, they had an obscure adverse event and now we're given this. Or they received so many additional imaging tests because TB was the last thing on the clinician's mind. So there's all of these costs that got put in. So we had to go back and revise 201 different costs at the end. This is just a brief thing that's in the supplement of just not meant to read it, just the number of items that we ended up having was extensive. Okay. So we used microcosting, bottom-up ingredients approach for every period except for the public health interventions period. Why? I already alluded to it earlier. Apart from the number of contacts, we don't have that information on contact investigation in the charts. And it's not really possible to cost on a per patient basis, right? I alluded it can be very complex. It's different variable. So you can use a top-down approach for this to estimate the average cost of investigating one contact. We were very lucky that one of our co-authors, co-investigators, Elizabeth Ray, was the head of the TB prevention and care program in Toronto. And so she actually oversaw all the contact investigations that go on there. And she helped us gather information on the personnel time associated with these investigations. Now, it'd be a whole other study actually to go and accurately cost these, because you have to know what's going on in the contact investigations. They need to get into the patient charts of who was identified and seeing what was done. So frankly, we're already on year 3 of this study by this point. We understood this was going to be an underestimate, but we only looked at the personnel time associated with contact investigations here. We figured out who was involved in the Toronto Public Health Department and found out that there was 22 public health nurse TB case managers that dedicate 2 of 5 days a week to TB contact investigations. So they're very difficult, time consuming, a lot of administrative work, a lot of chasing down people, right? Talking to people. And 5 regional clerks that dedicated 25% of their time. So in 2017, they had 1,689 contacts identified. The annual salary, including benefits in that year of the case manager, was about 100,000. The regional clerk around 80,000. When you look at the total cost, you have the total cost per person for the number of the 22 case managers and the 5 regional clerks, apportion it based on their effort level. And you end up with an overall cost of almost $1 million spent on contact investigations in Toronto, and a cost of $577 per contact identified, which surprisingly, or interestingly, when you go back to Dick's original study in 2004, where they did top-down, looked at what the budget was per contact identified, and you inflated it to this value, it was pretty much identical, which was kind of interesting and a neat finding at the end of the day. But we found that they might have slightly overestimated TB disease treatment. And I'll get back to why that's an issue and how you should be applying this on our end. That's not a problem with their methods. That's the problem with ours. So briefly, we included 90 people with TB infection and drug-susceptible TB. Drug-resistant TB is a bit less common. About 10% of people developing TB disease have isoniazid resistance, so in this third column, and 1 to 2%, if that, have multi-drug resistant TB. So not exactly an easy thing to find in the charts. In Montreal, we only treated 6 over about what looks like a 6-year period. So 1 person a year. West Park Healthcare Center, which I said was a very where patients with complex treatment go, 45, and the BC-CDC 11. So really not a whole lot of people with these, but makes it very useful because these rare events actually end up being the most expensive to care for. So we found to treat and care, diagnose, treat, follow up, etc. People with TB infection was $917 for the healthcare system on average across the 3 provinces. For people with drug-susceptible tuberculosis, almost $16,000 to treat, diagnose, treat, follow up, etc. Isoniazid-resistant TB, you need to treat for, so you go from 6 months treatment regimen with drug-susceptible TB to about a 9-month with isoniazid-resistant TB. Bit shorter now, but at the time it was 9 months. And then multi-drug resistant TB was 132,000. And that's about an 18 to 20-month regimen. So you see TB infection, to treat TB infection, which is asymptomatic, but you treat it to prevent tuberculosis disease, 17 times less expensive than drug-susceptible TB, 35 times less expensive than isoniazid-resistant TB, and 144 times less expensive than multi-drug resistant TB. So useful to help make decisions. What's the value of prevention, for example? How many people can you identify and treat, right, to prevent these downstream costs? Of course, there's many more things that go into your decision, but cost will help you make that decision. And we look at the relative contributions of different costs. So the orange one on the far left, that represents your treatment costs. The blue is diagnosis. Green are your public health costs, and gray is your hospitalization costs. So you can see TB infection, people aren't hospitalized, asymptomatic, given a drug, take it please, and vast majority of people are just fine. Drug susceptible TB in the second bar, more than half the costs are associated with hospitalization. Isoniazid resistant TB, 3/5. And then there's something a bit different with multi-drug resistant TB. Treated for longer, generally hospitalized for much longer than people with drug susceptible or isoniazid resistant, but the share of cost is much lower and treatment is the biggest contributor. The obvious answer might be that treatments for multi-drug resistant TB are very expensive. You lose your two best drugs that are off patent, very cheap. All 4 first-line drugs are off patent. Now you're going in actually some off-patent drugs, but they have such a small patient population that they serve to that they charge an exorbitant amount for it. So there's one drug, cycloserine, $60,000 per person to treat with that. And that was newly recommended first-line drug for multi-drug resistant TB in 2018. $60,000 here to treat. It's not much cheaper in South Africa or Brazil, you know, these places where there's a lot more people with multi-drug resistant TB comparatively. We found that age and sex were not particularly strong predictors of cost. I apologize, I have no idea what it is. Oh, excellent. Okay. I'm right at the end, so that's good. Unsurprisingly, extended hospitalization and number of people who had come into contact with the index patient were most strongly associated with higher costs of TB care. Extended hospitalization, 2 to 4 times higher costs. Each additional contact added 1 to 5% to overall costs. For people with TB infection, shorter regimens had a lower cost, while for people with multi-drug resistant TB who had additional drug resistance, it's now very complicated to treat, substantially higher costs, 40% higher than the 132,000. At that point, no, that's just baseline to investigate. Now, the value that you get back, if you didn't do it, you'd have to do a full economic evaluation. Kevin will talk about that decision analysis where we do this, we don't do that, what are the consequences? Talking right now just up front of what's going to cost. And then those feed into probably every single other talk that we'll have in this series. So how can you use these? Just a very brief overview. Contact investigations are very expensive, $600 a person. Approximately, some contact investigations have hundreds of people. I've heard stories of people who are infectious, get missed on a diagnostic test, or their culture comes back 6 weeks later positive. They've already gotten on a bus, for example, because of low suspicion. It's more of a precautionary sample that's taken. They're gone cross-province, mingling. Maybe they're sleeping in multiple different shelters, right? There's a lot of exposure that happens and a lot of people that need to be followed up and identified. Fewer contacts to investigate, the cheaper care is. Early case detection and prompt diagnosis, therefore, might be important. If you can diagnose people early, they expose fewer people. You don't have to investigate as many contacts. Same thing with hospitalization. If you can diagnose people before they are so ill that they need to be hospitalized, might save money. TB prevention, so treatment of infection, much cheaper than treatment of disease. So we're using this, as I said, to model the cost effectiveness of TB prevention among high-risk populations. So of course, we put in here, we say it's $920 to identify and treat a person with TB infection. But in Canada, you might have to test, depending on what population you're testing, up to 90 to 100 people to identify one person. So you then need to, right? So that's what, when in the original analysis in 2004, they accounted for all those costs, right? That's why cost per case or cost per case treated are a bit higher than what we estimate, because they have all of these extraneous things that go into a budget that we don't capture here. But in a model, we could include costs of now diagnosing or screening a bunch of people because we have those costs explicitly pulled out. Hospitalization, major driver of costs. Shorter, better tolerated regimens might have a significant impact on overall cost of care. And some TB medications, one I mentioned was cycloserine, $62,000 price tag. Even newer regimens use newer drugs. One of them is going to, cost somewhere from $15,000 to $30,000, depending on what day of the week you're looking at the price list. So it's shorter, but medication is still very expensive, not necessarily affordable. But in higher TB burden countries, there's now a lot of movement on TB medication pricing. So they actually are getting more into a more affordable range for treatment. And now actually the issue is diagnostics are very expensive. So trying to push down the diagnostics. You now have argued to get treatment costs lower, but now you can't afford to test everybody you need to test because you're going to bankrupt your healthcare system. If you test everyone, for example, in South Africa, which is what they want to roll out, every single person coming into care who's been exposed to TB prevalence there is about 1 to 2%. So 1 in 100, 1 in 50 people approximately have infectious TB. You want to screen everybody with a test that's $10 per cartridge plus, probably around $25, $30 a test. It's going to really drive up healthcare budgets. So a lot of effort now to reduce those costs. So these are kind of how you can use some of these cost estimates just generally without further research, or you can apply them to more complicated dynamic transmission models, use them for budgets, healthcare budgeting, decision analysis. Okay, so I'm gonna just shift gears quickly because for the core investigators, we do have a special call. So Global Health Programs every year puts out calls for faculty proposals. Generally, they're a global health related topic. What happens is faculty submit proposals. They get judged whether they're appropriate, and then they get posted, and undergrad students or grad students generally apply to them, and then they get matched. They apply to a project, and you get to interview and select a scholar, so a student to work with you for about 6 weeks between May and August at a mutually agreed upon time. So it's free to you. You get the student stipend is fully covered. You have a student that can work with you for 6 weeks on a project to try and move it forward. Any time beyond that is covered by you, but this is what Global Health Programs does. So we've put in a new call. So there's enough funding for 4 students specific to core investigators called the Informed Investment in Health Innovation Scholars. So what happens here, I'll leave the timelines and dates up here. They'll be posted. What happens is by submission deadline in November, you have to submit a faculty or a project submission that has a main focus of thinking about costs or economic evaluation in your research. So something where you would like a student to help you do some costing, whether that is you want to go and do some chart review, you want to liaise with the finance department to work on MRNs to try and pull out some costs. You want to go think about determining reimbursement costs for certain aspects of clinical care. You have a new cohort study that's already going and you want some work to be done to identify what cost you're going to need to get. So what comes with this, you're on your own to put the initial proposal in. I know not everybody here is comfortable with costs and doing this work. You get paired, so we have 4 projects. You get paired with someone like me or Kevin or Alton Russell in EBOH or Nisha Almeida, who will work with you to refine the methods here and then provide pro bono advisory time in the form of 2 2-hour meetings, 8 hours total over the project period, pro bono, no expectation of publication. This comes with your funding of also $2,500 for an undergrad student to work with you. And they will help improve, work on the methods, the approach, and then also some interpretation at the end. If you want more work than that, I think most of us are open to it, but then that comes with some discussion on appropriate recognition. So there's some pro bono time included with people with methodologic expertise to hopefully encourage you to apply and not be afraid. If you have an interesting question, please put a submission in and we'll work with you to refine the methods and work with you when the student's with you over the summer. Okay. I said all of this. Again, it's limited to core investigators. We look for interdisciplinary research primarily and involvement of ECRs. I kind of led this. I'm an ECR. I'm a little bit, soft to them. So those are what we're going to try and prioritize. But we have 4 projects that we can fund. Global. So we'll use things that can be applied not just at the chest or not just at the MUHC. Something that might have global impact. So I know there's people that do clinical research that might have impact beyond the boundaries of the island, let's say. And we definitely will fund one that has direct application to low and middle income countries. So if you're looking at something, you have a project that's sitting on the shelf that you want to go back and look at the cost for, that's perfect. Something that, remember, this is targeted to undergrad students. Okay, I'll stop there. Acknowledgements. Thank you. I'm hoping I'm at a few minutes for questions, maybe. Excellent. All right, thanks.
Great, thank you, Jonathan. Thank you, Dr. Campbell. So we have 1 minute, but I think very quickly, Jonathan, if you could answer quickly, if you could see chat message box, I think Sasha asked the question around the 20th minutes. If you could quickly answer. Meantime, we have 4 students in the room. So if someone has one question, burning question, let's ask him a question.
Yeah, sorry, so are we talking about which one are we talking about? The US cartridge pricing?
I don't know. Is that how okay.
No, all right, no. I will read out the question and I'll answer them. So one is about the US drug costs going everywhere. Healthcare systems means they can't negotiate pricing down. In some cases, actually, specifically TB drugs or some of these things where it's developed in the US and only marketed there and they're on patent, they need to be bought by or distributed at the global level by, there's a function that actually Canada had contributed to for TB called the Global Drug Facility. So they negotiate down prices where countries can procure through a central negotiating mechanism. So US drug prices don't necessarily need to go everywhere, but what ends up happening is if you don't have a health system that can negotiate for lower costs or negotiate a lower cost because we're going to buy a ton of drugs, so we can get it down at a lower level cost of, economies of scale. Sometimes you don't have a huge amount of price reduction. The Global Drug Facility is a major negotiating body for like 100 and some odd countries that can buy in bulk amounts at very low prices. So through that, we got the price of the drug bedaquiline down substantially from where it was, about 3,000 at one point down to something like $150 like right now. I see the follow-up comment on the expert cartridge. Yeah, exactly. John Green had one of those things. He was pushing at them for cost of bedaquiline, then started pushing on cost of expert cartridges. So they were $10. Now they're $7. So pressure does help because, yeah, they basically are profiting off of other people's misfortune. Sorry, do you want me to just run through the comments here? I think there might be one more.
Hold on. Do we have any question here? Okay.
Yes, Emma had yeah, exactly. Okay, similar comment. Okay, Ben.
So I think no
Hiroshi,
question from your side. Okay.
Hiroshi, I have 2 questions on our side. I'll repeat them, and then do you have comments there? Because then I'll go back to them.
We are good here. So if you have a question at your side, please go ahead. But we cannot hear, so you have to speak the question as well.
I'll repeat.
Please. Thank you. One new message.
Whether or not this component, because it's very much dependent on
right.
Succeeded in space. Is it all about health economics, or is it?
No. So the question is, recognizing costs are important but difficult when writing an initial grant to get funding. Do you put cost as an outcome or an objective that you want to collect over clinical impact or other aspects? And do you do cost-specific grant proposals, or are they just like one component? So I would say I don't put in cost effectiveness. We've had one grant that was successful on a pure modeling project, but that was not just costs. That was a lot of complex modeling that went into it as well. In terms of costs on its own, the ones that I've had that were successful have it as one outcome or objective, not as the be all end all. So we find also risk or clinical impact, and then also cost, and then put those together for economic evaluation at the end. I think if you're doing a clinical trial or you're putting on a cohort study or doing a cohort study, the addition of cost at the beginning, there's, you know, an additional effort level that'll be needed. But actually, if you have it done well early on, you can do a lot of the cost collection activities during the trial, and it's actually not a big marginal increase in effort overall. If you do it at the end, you'll sometimes realize, oh shit, I should have had that in my CRF, or we should have requested this data or consent for this from participants, so we can go back and get the information we need for costs. So I think you don't necessarily need a very detailed component in a 10-page CIHR grant where, you know, about 5 to 6 pages are your methods, and usually you have a lot. But like a paragraph or two saying that costs can be collected, and we have obviously good language to try and help work it through. And I think, as you've experienced, sometimes reviewers like just to say that costs are being collected, but sometimes they like very detailed methods that come with it. So it's just trying to figure out the balance. But I'd say definitely don't not put them in because you think it's just an extraneous thing. It really helps kind of push it forward, because if it's like you're doing an early stage study, all right, we know costs are an issue. This is something that you can branch off a research program or another area of research down the line. And then when you're done, you have something to say, okay, here's the cost effectiveness. Nandini, yes. Yeah, well, they better be. Yeah. Oh, okay. Yes. Yes.
Are these kind of studies really conducted in the same comparable population? Who is getting those, preventive treatments? What's the uncertainty around those estimates? Are there any
Yes.
that are done the same group of people are likely to develop?
Yeah. So the question, just for everybody not in the room, was on the TB prevention example, costs of TB preventive treatment versus costs of disease, and if the estimates are from people who are likely to be targeted by a TB prevention intervention, for example. And I'll say here, these are chart reviews, so they were people who were targeted for preventive treatment. Here at the CHEST, that's largely people who have post-immigration medical surveillance flagged. So a lot of post-immigration follow-ups. Proportion of people newly immigrating to Canada with TB infections, about 25%, much higher in some population groups. So that is definitely one group that is targeted here. And actually the vast majority of people treated here, 90% were born outside of Canada. So they are the group that's actually, when we talk about guidelines and TB prevention, that we've done the study, that have been included in the study. The newer, we have inclusion of newer regimens as well. And some other populations, people who are about to begin dialysis or, start immunosuppressive treatment like TNF-alpha inhibitors, for example, they're also included in here. When we do our particularly costing, so here we have costs of treatment, but we also have all the component costs. Like our appendix is super detailed in terms of, where costs go, what contributed costs A, B, or C to this stage. We have measures of uncertainty. For this presentation, I kept it simple, but in the document we have clear measures of uncertainty and by different subgroups. And yeah, in our work, I've done specific screening among people with dialysis. So pre-dialysis screening versus not screening for TB infection, and the cost effectiveness used some health administrative data to inform healthcare utilization. And we had some preemptive analysis on what it would cost to screen and treat upstream. Thank you. Yep. Yes. That is the answer. Yeah, the question is, the most recent one on the faculty submissions, yeah, various health sectors. The thing is, if you're outside of core, you need to be partnered with a core researcher. I think that's the key. It's a core specific funding call. But yeah, it is not necessarily TB. It's not a domain specific. It's health research that could benefit from, or where a question that you think would benefit or be improved by consideration of costs. And yeah, it's just meant
Thank
to
you, Jonathon.
start it up.
Sorry,
Go ahead, Hiroshi.
Sorry, I think almost 10 after 5. We have to vacate the room soon. So, but thank you very much for your talk.
Thank you. My email, I think, was up somewhere. My Twitter, you can get in touch with me if needed. Happy to answer any questions.
And I think yes. And so if you could send me this call